I think this is being recorded. Okay, so we'll try to make this interactive. So what do you guys know about hyperlipidemia? Just throw a couple of things out there.
It comes with an increased risk of heart disease and stroke.
Okay, yeah, so that's a big one. That's why we care about this.
Typically identified via lipid panel. It's a fasting lab. We get it at the start of most admissions.
Yep, so lipid panel's the key element there, diagnostically. What are the things that you guys have knowledge gaps in? What's something that you wish you knew about hyperlipidemia but you don't?
Who should be on a statin or other medical therapy and who should not?
Okay, so that's sort of the meat of this discussion today. What else?
I guess maybe the differentiation and impact of like HDL versus LDL and that kind of stuff.
Yeah, so there's hypertriglyceridemia, there's low HDL, elevated LDL. Which one should we go after? What should be the primary target? With the ultimate end state of reducing cardiovascular mortality and morbidity. All right, so let's talk about that. So I think you guys identified some of these. So the big takeaway, I think, one of the questions you guys had asked me about hypertension is, well, should I be managing this? It's really up to you. But at minimum, when you do get that lipid panel, whether it's sort of part of an admission process or something that you do because you have someone this coming year on high risk medications and you get a lipid panel, the end state would be after this, you should feel comfortable in terms of figuring out who you need to tell, hey, you need to go see your PCM. So that's one thing. So that would be a new statin therapy or initiation of. And then also knowing who is not optimized. So in other words, what are the goals of therapy? So we'll talk about those as well. So let's begin with a case. So you have a 20-year-old single white male, 290 pounds, BMI of 37, quetiapine exposure for 8 years, gained a lot of weight, and physically inactive. Does this case sound familiar?
Yeah, it reminds me of James.
Well, James, you got to add some additional years to this, right? Aren't you in your 40s, James?
Not quite, sir. 32, and not quite 290 pounds yet either.
So this is the case from our initial hour, and I'm going to give you the lipid panel. I want you guys to write down what you think you need to write down so that you can then tell me whether or not you're going to start him on statin therapy or some other therapy. So I'll give you guys a second to write this information down. Okay. So who would start this gentleman on statin therapy or some other anti-lipidemic therapy?
Maybe recommending a Mediterranean diet or some omega-3 fatty acids as first line.
Okay, so you're gonna ask him to go start fish oil.
It's just an option.
Okay.
I think definitely addressing lifestyle changes, possibly incorporating, physical exercise that he can tolerate, given his current medical status.
Okay. Anyone else?
I mean, this patient, he's 20 years old, and I mean, his LDL cholesterol is not above, like, I think the cutoff's 190 for starting somebody who's 20, who doesn't have a diagnosis of another condition. For sure to like start them on statin therapy. I mean, he's kind of on the young side. I think that he definitely has enough like risk factors, and even though he's not truly like pre-diabetic based on strictly his A1C, based on his insulin levels, and we already talked about last time, a couple times ago about his risk for developing diabetes, and he's already showing signs of insulin resistance. So I don't necessarily think it would be a bad idea to start him on something, especially given the fact that it looks like he's probably going to continue to be on a medication that's going to put him at higher risk of continuing to put on more weight and develop further cardiovascular risks.
Okay.
Yeah, I mean, if anything, I'd probably be more worried about his potential pre-diabetes, because in my head, the things that I remember is like ASCVD risk, and then the LDL, and then whether or not they're diabetic. It doesn't seem as if this person is diabetic. I don't know what his ASCVD is risk. I don't have his blood pressure, and then I guess no, I wouldn't start this guy on a statin right away. Looks enticing though.
Well, and you can't really measure his 10-year risk because he's so young in the.
Oh yeah, it's 21. Never mind.
Yeah. So who would not start him on a statin?
I would collaboratively work with the patient to see if he wanted to start a statin.
Okay. So you think that, what if he says, yes, start me on statin, sign me up, or you're his PCM? What would be the end state?
Well, I think discussing like just the potential like trajectory of, lifestyle first, then medications aren't going to go anywhere. Kind of like, oh, we'll do therapy before we start on an SSRI, or like, kind of, I think trying to give him the options and not necessarily start one right away, but putting it in his head that this could be a potential, outcome for him in his future.
Yeah. Who would definitely start him if he was 55-year-old?
I would. I'd refer back to the AAFP guidelines on management of cholesterol. If he was older than 40, then he meets criteria for high intensity statin based on his LDL alone.
Okay. And what happens, he's pre-diabetic. We had determined that essentially he's got insulin resistance. If we did start him on a statin, would that increase his risk of diabetes or reduce his risk of diabetes?
I'm not really familiar with any direct correlations with statins and diabetes, but I mean, um, if he's healthier in one way, maybe he'll be healthier in the other. I don't know. I'm not familiar with anything that says statins stop diabetes.
I think it might actually increase his risk.
Yes, it does. It is associated with increased risk of inducing diabetes. So that's one of the number, sort of a harm associated with it. It's about, the number needed to harm is about 204 in people that are baseline. And this gentleman may be, you know, slightly more, but when you look at the pros and cons, if someone qualifies for a statin, usually the benefit outweighs the harm, but you still got to let them know that, hey, there's a possibility of this being associated with diabetes. So no free lunch in medicine. So speaking of lunch, what this is illustrating is, I think, what James was earlier talking about, which is, you know, you've got lipid, essentially just different forms of fat that are highly hydrophobic, and they have to be transported. So how do they get transported?
In chylomicrons.
In all kinds of stuff, but ultimately your lipoproteins, right? So these things join forces here, and they're being transported, and it ends up leading to all this junk here. And not only do you have a bunch of kind of proteinaceous fatty deposits, but it also results in a lot of inflammation. So people often think that, you know, people get MIs or heart attacks as this start to, you know, get bigger and bigger and bigger, and it just squeezes the blood flow. In reality, you may have like a 10% plaque and it ruptures. And then there's sort of an immediate cascade with your platelets, and it immediately goes from 10% to 100%, right? And that leads to ischemia and myocardial death, or ischemia and cerebral events. And so these are all the sort of different atherosclerotic vascular diseases. I've listed some of them, but, you know, obviously there's the coronary artery disease that leads to all kinds of cardiac entities. You got your cerebrovascular disease, you got peripheral vascular disease, which can be pretty debilitating. And you have chronic kidney disease that's usually also related to vascular disease. And then as things get more and more severe, you can have, you know, other organs that are feeling ischemic sequelae. So people can have like ischemic bowel disease. You know, you might have like this older patient that when they eat, they start having severe abdominal pain because all of a sudden the oxygen demands in the gut go up, but they've got such bad vascular disease that there's a mismatch. And so a lot of the time, these people essentially have almost like operant conditioning, where they stop eating, and so they start losing weight. And that's sort of a classic story. You know, erectile dysfunction is another one. So all of the vasculature changes result in premature death and so on. So that's sort of the etiology. Now, so you can have genetic etiology, right? So there's a big element of that. And then you add lifestyle, so diet, lack of exercise, all of that have implications. And then you also have all these other reasons. So primary and secondary, and then iatrogenic causes like the antipsychotics here can add to this. Now, for alcohol, I think we had discussed this. What sort of changes do you usually see in patients with alcoholism? Does anyone remember?
Increased HDL.
Yeah. So they can have increased HDL, but they also may have increased LDL as well. And then, there's all kinds of other manifestation with alcoholism. Pretty much you get poison head to toe. And then what's the effect on the heart?
You get like a cardiomyopathy, or
Yeah, exactly. Right. So alcoholic cardiomyopathy. We talk a lot about the brain, but I've seen some really bad ones. Usually dilated cardiomyopathy. So these are some of the causes, secondary causes of hyperlipidemias. All right. So, there are all kinds of different categorization of these lipoproteins. So we talked about, the lipids plus the proteins that help carry these. And a lot of these things are still really not super clear in terms of what they all do. People often associate HDL as the one that takes protein from the periphery and back to the liver, for example. And so it has some protective effects, for example. But it's really a spectrum. So you go all the way from low density to high density. Actually, the sizes of these may be higher, even though, so density may be lower. So these are more compact. Almost think of like different planets. Some of the bigger planets have low density. They're big, but they don't weigh much. So unlike on a gel, you can see, things could be separated from each other based on their density. So these are the 4 groups that definitely need to be treated with statins. So one of them would be someone with existing atherosclerotic vascular disease. So that might be, people who have coronary artery disease, have had MI, cerebrovascular disease, known peripheral vascular disease, things like that. And then there are these people that have super, super high LDL. So if your LDL is greater than 190, then you bought yourself a statin. It doesn't matter who you are. So these two, right? So I've seen a couple of cases of people with LDL, and there's probably something genetic going on with them. The third group are diabetics, and usually there's this age range. And I doubt that in America you'll find a diabetic in this age group who happens to have a low LDL. So anyway, so if you got diabetes and you're 40 and above, you need to be treated. So a 20-year-old with like type 1 diabetes, which is not related to a metabolic syndrome type of phenomenon, they probably don't necessarily benefit from the statin. And then this gets complex, but these would be the patients that you'll likely be dealing with, where you need to put your thinking hat on. So if you get a lipid panel on someone and their LDL is greater than 70, then you need to figure out what their 10-year atherosclerotic vascular disease risk is. And I'll show you that calculator this hour. Any questions on this? So, you know, I think one of our ethical obligation is, as we do this, especially if we're going to exacerbate someone's hyperlipidemia, and you're going to get patients and you're going to have a handful of them who might end up fitting this, our ethical obligation is that we catch these and we get them to the right people. And we probably see them much more frequently in the psychiatric practice than they see, especially if they're young, like in their 40s, 50s. They're not seeing their primary care but once a year. So if you do catch them and you're not doing it yourself, you have a global supervisor who doesn't feel comfortable, refer them to their PCM, and then make sure that you follow up and that they have referred, so that, you know, we can sleep at night. Yeah, I have to give you this quetiapine dose because we have tried everything else and you haven't responded. So I have to give you that, but I'm going to make sure that we mitigate your risk and you get treated. So look out for this, and this may be one of those things that may be worthwhile just putting at your desk so that you can quickly refer to it. So here are some of the statins. Have you guys, which of these have you seen in your practice these last 2 years?
The atorvastatin and I think the rosuvastatin I've seen.
And I've seen simvastatin, but for some reason I was thinking that there really wasn't the mortality benefit in simvastatin. Maybe I'm just mistaken.
Yeah, so if you look at the chart, right, I have never heard of pitavastatin, and there's the reason right there. Fluvastatin, I have heard of it. I've never prescribed it, but there's no mortality or cardio or heart disease event benefit. So these are no. And then rosuvastatin actually is generic now. So so in my practice, I have used simvastatin, rosuvastatin, and atorvastatin, and I no longer prescribe simvastatin. One of the reasons is, as you see that little asterisk down here. So we used to give people simvastatin 80 milligrams, and then a lot of people were having, one of the issues associated with statin is the statin-induced myopathy, where people have a lot of aches and pains. And so it was extra bad with 80 milligrams. So they put a cap on it and said, don't go above 40 milligrams. Does that sound familiar to you guys with one of our SSRIs, which was associated with like QT prolongation? So FDA said,
Alexa.
yeah, FDA said don't use. And so it really difficult then to extrapolate clinical evidence, especially in studies where they were using, in terms of the Celexa, if they were using, 60 milligrams or higher. So anyway, so simvastatin also has a lot of drug-to-drug interaction. So like if you, certain calcium channel blocker, especially amlodipine, if someone is on amlodipine, it doubles the levels of simvastatin, for example. So I don't really use it. as you see there, it shows you how much LDL is reduced. So probably the most potent one that we have is rosuvastatin. And then it may, so the other thing that happens when you give people these statins, it not only does it lower their LDL, but in a lot of the time, it also drops the HDL a little bit. But that may not be true for rosuvastatin. So it may not. And then some people argue that it may slightly increase your HDL, which I personally don't believe. But my typical go-to is rosuvastatin or atorvastatin. So either of those. Let's see what else I wanted to. Now, what do you think the difference is? So let's take atorvastatin or Lipitor. You guys probably heard of it, right? So what do you think is the jump in LDL reduction when you go from 40 of atorvastatin to 80 of atorvastatin? Is it linear? You know?
I assume it's not linear. Probably like diminishing return the higher you get.
Yeah, that's a very wise statement. So here is the reduction in LDL based on changing doses. So like with rosuvastatin, right? You go from 20 to 40. There's not a big sort of bang for your buck. With atorvastatin, there's not a huge bang for your buck. And sort of the theme is there. So why would you think that, when we talk about management, one of the things is going to be like high intensity max dose. Why do you think that guidelines still want us to kind of maximize the dose of the statins, even though the return for as far as LDL reduction is not that much?
That's the dose that they used in the research studies.
Mm-hmm. Yeah, like atorvastatin, pretty much 80 milligrams. What's the other reason?
So the LDL level may not be the what's actually reducing mortality. Like the other theories about why statins reduce mortality, like reduced inflammation, that may not be necessarily related to the lower LDL level.
Yeah, exactly. So when we have people with acute MI, we start them on usually atorvastatin 80 right away. And the thinking is that it's the anti-inflammatory effect. People have even studied statins for acute delirium in the ICU. And some studies suggest some benefits. Okay, so that's the reason why you'll see that the recommended interventions are going to be different. So now there's also, we talked about the HDL reduction and how much it goes down. So the guidelines kind of divide up the statin therapies by their intensity. So some of it is the medication itself, and then the other element is the dosing. So you'll see atorvastatin at 10 milligram to 20 is considered moderate intensity, and then 40 to 80 is considered high intensity. Simvastatin is all alone here. So I don't really even operate in this. My patients either end up here or here, and it's usually rosuvastatin or atorvastatin. I don't really prescribe simvastatin. By the way, I got consulted by a psychiatrist buddy of mine who was deployed to New York, and they got these patients who also suffered MIs as part of their COVID, pneumonias, etc. And the only drug on the formulary of this, this combat hospital was simvastatin. So So I had to then recommend to him that he goes with simvastatin 40. But outside that, I don't really know a lot of people who prescribe simvastatin anymore. It's dirt cheap. Okay, so these are some of the outcomes. So this is reduction in non-fatal MIs and coronary heart disease death versus absolute LDL reduction. So what this shows, and this is adjusted, what this shows is that the dose matters when you look at kind of hard outcomes. So it matters how much you put someone on. And so when we look at the guidelines, I want you guys to remember this. These are some of the studies, all of these different, and you guys know in cardiologies, they love their acronym-based studies, the CARE study and the lipid study. And so the Jupiter study is a popular one. And so a lot of these support, that there's a dose effect on outcomes. All right, so I want you guys to take a mental image of this and hit the save button. And now this here, a lot of these studies, when it comes to looking at the plaques, usually they look at the carotid artery because it's easier to do, right? So they'll ultrasound and look at how the intimal thickness of the artery, and they'll see, well, it's 2 millimeter thick, and then they see if it goes down in thickness, and using that as a marker of reduction in the plaque or the gunk that's in the arteries. And so what you guys see in this cartoon is that as LDL goes down, when you treat people, their atheroma volume, or the change, so there's a greater change in the percent of their atheroma volume. So let me ask you guys this. So there's a tribe, I forgot whether it's in South America or Africa. There's a tribe who are still hunters and gatherers, and they're doing like 17,000 steps a day, even their older population, and they have their diet that's hunter and gatherer, a lot of nuts and things like that. Any idea what their average LDL is at baseline? And by the way, they don't really die of cardiovascular diseases.
I'm gonna guess that it's gonna be surprisingly higher, around 140.
Okay. Anybody else? The price is right.
I'm gonna go with 200.
200. So you guys are going up.
100.
How about low? It could also be low,
80.
right?
I think it's going to be low, 30 or 40.
Oh,
30. Go 85.
okay. All right. Actually, Alex was correct. It's in the 30s. So those people, so here in the US, we say, okay, if your LDL is less than 100, that's pretty good. Is it? Right? So I just want to highlight that these are kind of man-made numbers, right? If you truly look at a hunter-gatherer humans, their LDL runs in the 30s. So I think that our normal might have shifted significantly to the right based on our modern day living and so on. Does that make sense? So it's not surprising that the lower that you go, the more robust reduction there is in the plaque. And so here's my attempt at sorting this out. So usually you start, so anything below 0 is going to be a reduction in the volume. And so usually around 90, you could even trace it to 100. It looks kind of flat. So this is where that magic number less than LDL less than 100 comes in. And then for some of the population, it's going to say less than 70 because they're trying to reduce the vascular plaque. So anyway, so this is this is fairly convincing to see, and then the lower that you go, so there's some new treatments now, and non-statin, really expensive. You're talking about thousands of dollars. So the evolocumab, and it will drop your LDL into the 30s, actually. So these are actually patients in the 20s and 30s. And it really, it's really potent, very expensive right now. In the future, it may be a more mainstay, but it's sort of like a third line treatment right now in the right population. So these are the PCSK9 antibody treatments. All right. So remember the 4 populations that I gave you? So people that are over 21 that have clinical cardiovascular disease. And so this would be secondary prevention because they've had the event. Then the goal is to drop them below 70 and 50% reduction in their LDL. So baseline, if they're 130, then drop them by 50%, whatever is higher, essentially. If you got one of those people that happen to have no other, no primary issues, no events yet, but they happen to be running around with the LDL greater than 90. So our patient doesn't fit into this criteria. He was 21, I think, 20. His LDL was like 131 or 138. So does not fit into this, but these patients, the recommendation is you drop them below 100. And so again, looking back at this, and this is where sort of this magic number 100 comes from, because it kind of puts you there. But in a lot of clinicians say, screw this, I'm going to drop them to around less than 70, around 60 or so. These patients that have diabetes, but besides diabetes, they don't have any cardiovascular events yet, and they're between age 40 and 75. You want to drop them below 70. And then this is sort of the garden variety patients, 40 and above. I'm about to hit this, who have no coronary artery disease, no cerebrovascular disease, no diabetes, but they happen to be in the 70 to 189. And they have a 10-year risk of greater than 7.5. When you put them on statins, you're shooting for 30 to 49% LDL reduction. And so this may not be the perfect marker LDL. There's all this other anti-inflammatory effects going on. This is people with the disease. So people that have clinical disease secondary prevention, right? So obviously you emphasize healthy lifestyle. If they are high risk, you're going to start them on high intensity statin. So they end up on atorvastatin or Lipitor 80 or rosuvastatin or Crestor 40 milligrams. And if they're on maximal statin and they haven't met that less than 70 goal, then you add ezetimibe. And after ezetimibe, you would add the PCSK9 inhibitor, assuming that the patient has access to it and so on. Right now, it's super expensive, and we don't know if it's cost effective or not. Anyway, so usually the pathway is people get put on a statin and then ezetimibe. And then if they're still not at goal, consider this. People that are a very high risk. So this is the very high risk group. So a lot of these patients end up, if you got cardiovascular disease, you often end up on this side. But if they're not high risk and they're young, put them on high intensity, you treat them like this. If they're older, then they may not have a huge lifespan left. And so you just want to kind of do moderate intensity to kind of balance the weight of risk and benefits. Risk would be the whole diabetes potential and the myopathy. This is the primary prevention. So a lot of our patients end up falling in on this. So if you are someone with that greater than 190, you get put on high intensity. If you're diabetic, you get put on moderate intensity, but you may end up on high intensity depending on how you respond. I usually just treat these two groups the same in my practice, and I put them on high intensity. And if you're older, then you want to kind of risk benefit assessment. Okay, so here's where our patients are going to fit here somewhere, right? So ages 0 to 19. The familial hypercholesterolemia, these patients can have, you know, their cholesterol's in the hundreds to 1,000. Sometimes you got to do apheresis with these patients. You know, with like hypertriglyceridemia, they can get pancreatitis, things like that. So we're not really dealing with this population. This is where our patient fell. So he was 20, estimate lifetime risk. Consider statin if he has family history, and LDL greater than 160. So he doesn't really fall into this because LDL was like 138. So no statin indicated. And then this would be your garden variety patient population who are not diabetic and they don't have the 10-year risk. Without diabetes, 10-year risk factors. So this is your garden variety patient population, 40 and older. You do the 10-year cardiovascular disease risk, and then if they are greater than 7.5, then it favors statin. And then the goal is 30 to 49% reduction, moderate intensity. If they're super high, you put them, you definitely try to treat them almost like secondary prevention. And you try to get their LDL reduced by more than 50%. In this age, in this population, you can consider statin therapy if they have other risk factors, and we'll go into some of those in a second, and I'll show you what the guidelines recommend. So you can do the 10-year risk assessment, but there are also calculators where you can plug in their high sensitivity CRP, looking at how much inflammation they have, and they may end up going higher on the scale. The ABI index is looking at peripheral vascular disease, so it's a dirt cheap test, and if they have peripheral, vascular disease, then they probably have coronary artery disease. You can also get fancy, and even in this population, I've had one patient where I ended up recommending a CAC scan. So not like our CAC card, but it's a calcium channel, calcium score. And I'll tell you more about that in a second here. But you can kind of break the tie. If they fall under this group and they're not sure whether or not they should take statin, you can say, well, I can dig up some more data and then we can make a better informed decision. And you can look at their primary care can look at. I wouldn't recommend you guys ordering these calcium score CT scans on people in our psychiatric practice. These are some of the risk factors. And so one of them that you'll see here is So this one, I am South Asian by ancestry. So this one, you know, I try to remember this. So people of my ancestry tend to drop dead from cardiovascular disease, even at lower LDLs for some reason. And so my ethnicity has been put here, but you got the metabolic syndrome. So, you know, our patient is young, but if he was 41, let's say, he would have probably qualified for a statin based on presence of metabolic syndrome, presence of triglyceridemia, if the triglycerides are greater than 150, I believe. And where is the, I thought it was in here. By the way, look at all these other inflammatory diseases that can also raise your risk. So you treat them differently. This is from Up to Date. And essentially, if you're in this group, one of the things that they recommend is essentially discussion or calcium score to break the tie.
Dr. Amin, I have a question for you. This is Cecily.
Yes, hi.
I know you keep saying our patient is young and some of these don't apply to him and stuff, but if you look at him like over quote unquote his lifetime, he started the quetiapine when he was 12, gained the 200 pounds in the first 2 years. We don't, based on the information you gave us, don't have these numbers from before, but I feel like we could fairly say he might have been hanging out in some of these numbers for a couple years now. Does that change how you look at these charts and how you would medicate him? Or do we just continue to wait until he hits these ages and has an event to then make him fit the chart?
Yeah, so that's a good question. So right now he would fall under primary prevention. He does not have any secondary manifestations yet. He doesn't have, you know, any kind of peripheral vascular manifestation, doesn't have heart disease as far as we know. And so a lot of the data comes from population where people that were his age didn't really apply, right? So at the end of the day, he's so young. Is he going to be taking statins for 60 years if he lives to 80, for example? So the age piece is important. So if he does not have the LDL of greater than 160 plus family history at this age, then he doesn't really fall into this group.
But I guess I'm also looking at the risk enhancers, and he already qualifies for metabolic syndrome and already has an elevated triglyceride. So does that play any like effect in how we look at this chart? I mean, I feel like this is maybe a unique case because he is so young, but although he doesn't meet that, do you have to take into account like the other ASCVD risk enhancers?
So in this case, you would individually target those risks themselves. So you would target the metabolic syndrome, for example. So when I put him on metformin, actually his triglyceride is going to come down and his HDL is going to go up. And I'll send you guys the results when I get those labs on him next in a couple of months. But that's just going to happen. So you try to go after the individual risks, right? So encourage lifestyle to reduce those individual risks, and then just ultimately applying whether or not they're going to benefit. It just purely the cutoff is 160. So once he hit 40, though, he's probably going to end up in this, and he will likely check a bunch of boxes because he's going to be hypertensive, et cetera, and his 10-year risk is going to go up. And if he started smoking, for example, that's going to raise his risk. So if someone is in this group, yeah, please do target these. You can't target people's ethnicity, but target the ones that are modifiable. And for us, this is going to be the metabolic syndrome. So that's why we're doing all of these, because we have split them artificially, but they're all related to each other. This is just an example of the calcium score. So this is 0, nothing glows. Look, you see that little speck of calcium? Here's a bunch of calcium, and look at this whole thing is calcified. So what that means is this patient has at least stable coronary artery disease. Calcified lesions don't tend to rupture, so that's a good thing. But then you put them on statin, and that's supposed to protect them further from rupturing. This just gives you a sense of how much radiation these things have. So coronary artery calcium scan has 1 millisieverts. Let's see, this is just I thought I had another chart here, which I forgot to add, but it takes about 4 months from 1 millisieverts of radiation to kind of get out of your body. It takes about a day for the chest x-ray one. So anyway, so that was the overall discussion. Do you guys have any other questions? Oh, look, we have a new student in the class. Do you guys have any other questions? All right, quick feedback from me before we end this.